And we have the last of the academic sessions lined up in the next 30 minutes. We would be discussing induction therapy in 2023. Definitely a difficult task to discuss, but let's have the moderator, Dr. Manish Malik, with his panel members, Dr. R.K. Sharma, Dr. Pratim Sen Gupta, Dr. T.K. Saha, and Dr. P.P. Verma. The chairpersons for this session, may I invite them on the dais, Dr. Vishal Saxena, Dr. Ritesh Sharma, Dr. Ram, and Dr. Sundar.
Thank you so much, sir, for inviting me here. And I would want to thank you till my slides come up on behalf of all of us in the hall for this academic feast and the impending culinary feast also. So the topic of discussion was induction therapy in 2023. And this is what 2022 looked like. There were around 8,000 transplants done in 2022, out of which 17% no induction, 83% induction. Out of induction, 80 LG or Graflon 42%, 80G or Thymo 41%, and Basiliximab 17%. This year, 3 months, 2,000 odd transplants, again 16% no induction, 30% Graflon, 54% Thymo, and 16% Simulex. So this is internal data from Zydus, but I think fairly reliable data. This is what we all practice. So the opening batsman is Dr. R.K. Sharma. So the first query to you, sir, is how do you risk profile patients and how you choose the induction agent, depleting versus non-depleting? This is how we begin the show, and then let's see how things move forward.
Good evening, ladies and gentlemen. At the outset, I would say that induction therapy, the way it has evolved, still remains an empirical therapy, center-specific and clinician-specific. So the first question you're asking is risk profiling of these patients and choosing the induction agent. The risk profiling, what you have to understand is the criteria has to be simple. If you complicate it too much, the clinicians would not find it very useful. The basic definition at present is if out of 4 or 5 criteria, if anybody has one criteria which is there, he is put as a high risk patient. And what is generally used is more than one or even one HLA mismatch. If there is an older donor who is donating to a younger person, if you have a PRA which is more than 20%, if there is ABO incompatibility, if in a deceased organ donation you have cold ischemia time which is more than 24 hours, and if you expect a delayed graft function. So out of these criteria, even if somebody is having one criteria which is there, he will be listed as a possibly a high risk profile. And you can see from this simple criteria description, most of the patients where they would fare. The data which we have shown, even in India, almost 20% of the patients do not get induction.
That was my second question for you. You were the opening batsman, so the first was open time, but now it's only 2 minutes per question as requested by Dr. Khanna sir. So which set of patients you think can do without induction therapy? Because it's a huge number. 15% is a fairly good number of not getting induction therapy. And I think money cannot be the only reason. It is the clinician's choice of not giving the therapy. So what kind of patients you think could be ones without induction, but without compromising the outcomes? And let's not put money in there. Let's forget the money part, the cost part of it, other than money part, sir.
I would say that in a living donation, if it is an HLA identical or twin donation. Second, if somebody is already having a functioning solid organ transplant, like a liver transplant, heart transplant, or a lung transplant, if he's going for a kidney transplant, he may not require induction unless he has one of those high risk criteria. That you have to keep in mind. Even if there is an HLA identical donor, if he has ABO incompatibility or one of those criteria, you have to think whether to give induction.
Yeah, because I still feel that 15% is too huge a number just to fulfill these two criteria of an existing solid organ transplant like a liver transplant or HL identical. So there must be other things on the clinician's mind which have held us. So the next thing, Dr. Pratim Singh Gupta, basiliximab is almost 15 to 20%. So what do you think are the indications and the usage pattern for this molecule, IL-2 inhibitor?
Yeah, so when we think about transplant inductions, practically we have three agents in our hand. So among the not depleting antibodies, basiliximab is most commonly used. Now, if you look at the evidences, published evidences, majority of these trials of the basiliximab and all the depleting antibodies, they are non-inferiority trials. They have shown similar efficacy, but we, the clinician, when we use it practically in our day-to-day care, we all know, we all have a feeling that it is to some extent weaker in terms of potency, in terms of preventing rejections. Having said that, there are a lot of places where basiliximab can be fit well. For example, when you are using in avian compatible additional with rituximab IVIG, you don't want to load further with the depleting antibodies. This is a good. And obviously in the low risk patients, Sir has already mentioned by which we should define which is high risk and low risk. In low risk cases, basiliximab is a good choice, keeping in mind the chances of infections be less, even though the data shows that there are compatible infections. But however, it is our good feel, but we all feel that the chances of viral infection, BK, VCMP are comparatively less. So my take on the basiliximab selecting as the low risk patients, and also when we are using in a highly sensitized patients and even compatible other depleting, other modalities of inductions like rituximab, IVIGs, in those cases, we also can consider basiliximab as another injection.
Thank you so much, sir. So I think running on time. So again, this question again comes back to you. We have in our market now ATG and ATLG both. ATG is Thymo, ATLG is Graflon. So it is a very, I think, a very difficult question. Which to use and when to use?
Is it just a market pressure? The question is majority of the data we have with the thymoglobulin. The time when the thymoglobulin was not available in the India, that was the time we gained confidence of using ATLG in the form of Grafalon. But if you ask me, in between you have a Grafalon and you have ATG, what should you use? I'll definitely choose for the thymoglobulin.
But would there be some patients who are not that high risk, not that low risk, somewhere in the midline, where you would want to use induction therapy, but maybe have slightly lower risk of infection, maybe as mentioned in the literature. So would there be a place for ATLG somewhere in between basiliximab and ATG?
The question is whether ATLG and the ATG, is there any data in terms of less infection risk? Answer is no.
So I take it there, and
that's my personal opinion. A lot of people have tried both Grafalon and ATG. Some of the studies, I think Dr. K's group feels that the equivalent dose of Grafalon is 9 milligram per kg, though the recommended people are using 6. So effect is almost identical. Your question was, whenever I find that the risk is less, I do not hesitate using Grafalon. But if the patient has got high risk, we certainly go to ATG.
No, of course, never dependent, never. It's dependent totally on you and nobody else. Any which ways. So that question of dose which you raised, so we come to Dr. T.K. Saha. What is the dose of ATG and ATLG, practical versus theoretical? As Dr. Verma said, it's a 9 milligram for ATLG, which is mentioned, but we never use 9 milligram generally. And same for ATG. So I would want your comments on what the literature says, what the product insert says, and what we use in real practice, both for both molecules.
Look, these literature always says to use ATG 6 milligram upfront. And if you try to sort of go for the equivalent dose, it will be 2 or 2.5 times for the ATLG. But in India, we know that very few people.
Mike, sir, Mike.
Hello. Yeah, hello.
Yeah.
Yeah. In India, we know that very few people will use 6 milligram. But having said that, now probably there is more confidence is coming. And I myself use at least 3 milligram of ATG upfront. And then depending on the day 1 or day 2, the condition of the patient, I add another 1 or 2 milligram more of those, depending on the condition of the patient and the risk profile. So upfront, I use 3 milligram, but I know that many of my colleagues are using only 1.5 or 2 milligram upfront ATG. And there are few studies, Indian studies, which says that this is effective. But in a large scale, no international study has shown that low dose is effective. Because of the fear of infection, we are using less dose, but I do not know whether it is justified or not. My personal opinion is that we should use at least 3 milligram upfront.
And regarding ATLG?
Yeah, the conversion is always about 2 to 2.5. So if you 6 milligram minimum, preferably 8 milligram.
Because the graph.
2.5 actually.
Yeah, the graph registry data showed a dose of 6 plus minus 2, and the variation was from 100 milligram to 900 milligram. So that has been the kind of variation in the country for use of this molecule. And the second question also comes to you. As you mentioned, it is recommended to use probably a single dose as induction, but you have mentioned use of a split dose. You give a 3 milligram at induction, and then you decide on the second, third day. So what do you think is a better protocol or a recommended protocol regarding a single dose at induction or split dosing, 2 doses, 3 doses, 4 doses, as one may choose?
Yeah. Actually, I'm just reading this topic a few hours back, and I found a very latest Taiwan study where they have compared the upfront dose versus the 3 or 4 dose together on subsequent time. At the end of the day, the conclusion was that upfront is better because otherwise you miss the dose in few patients. Basically, because of fear, we are not giving the upfront dose. So it has got some benefit that we give upfront a moderate dose, about 3 milligram, and then decide the subsequent dose. Well, if your patient has got a high risk profile, we do risk profiling before deciding the dose, then giving upfront of 4 or 5 milligram is more justified than 3 milligram itself.
A problem with upfront dose, maybe if the transplant gets cancelled, you're given a 9 milligram dose, and for some reason the patient has fever or something else happens, then that antibody is still in his body. Maybe.
But then how it will be cancelled? Because in most on the table, we give it before, not on the table. Actually, there is one more point here, that at least 50% of dose should be given before the declamping. If you read the ATG insert, and I've read many literatures, because I was having that problem in cadaver transplantation, because it was cadaver transplantation done in so much in a hurry that we start the ATG and immediately the surgery is done. Then I made it a point that unless patient gets 1 hour of ATG at KTU, I will not ship the patient to the theater. Because some surgeons are very smart. They do the surgery so fast that when I see that patient has come back from the theater and still 50% ATG has not gone. So one has to ensure that the 50% ATG or ATLG, whatever it is, goes before the declamping.
Because at our center in Gangaram, the policy is to finish off the induction before moving to the operation theater.
So that is 6 hours. So
Yeah.
that means in a disease donor program, 6 hours
You cannot.
time
Agree.
after everything is done, your ischemic time will go up.
No, I'm talking of just a live program.
No, I'm talking morely in terms of a
No,
disease donor,
this
but-
is the protocol also followed. Most of the centers give ATG that is spanned over 6 hours just before sending to OT, they finish it off. The recommendation is that at least 50% should have gone
Yeah.
prior to opening the clamps.
Yeah, but
But there
what
is
you are
no-
telling is feasible in live donor.
Yeah, live dose.
In disease donor program, in our center more disease.
Actually, we start the infusion before the patient is being shifted, but it is being continued in the operation theater. The 9 milligram dose of Grafalon, if you want to give a front, it has to be intraoperative. The most of the regimes for giving the total dose is actually intraoperative. So there is no question of the transplant being postponed.
Still,
Yeah,
So those,
there is
but
no
it
question.
can happen. for us.
that was a personal concern I had.
Oh,
I
that
don't know
happens in centers where they're being given
reason.
shifting to the OR.
Yeah, so
So next, I again come to Dr. TK Saha. How do we monitor induction? Some people use ALCs, some may use CD, some may use CBCs, the HbTLC platelet. What do you suggest we should use as monitoring, or just a impulse that we gave him 300, now everything is fine, third day maybe give him 100 more. So what
yeah,
is there?
it is, initially it used to be CD3, then it came the ALC. Now I have read and discussed with the most of the international authorities. They say that just give it unless your total count forces you to stop it, which is less than 3,000, or platelet count, which forces you to stop, which is less than 40,000. But this is also recommended that you should keep your absolute lymphocyte count to as low as possible, preferably below 100. So when I pass my comment that I give 3 mg upfront and then I try to see and then give it another dose, I always look into the absolute lymphocyte count. If I see that absolute lymphocyte count, more than 150, 200, I tend to give one more dose.
Yeah. So coming to a very specific scenario, ABO compatible transplant, numbers are increasing, policy is still not standardized. So Dr. R.K. Sharma will probably guide us about the induction in ABO compatible transplant.
Again, I'm making a point. We have had discussion in ABO incompatible transplant. Most of the centers are using interleukin-2 receptor blocking antibodies rather than thymoglobulin. But I can tell you that in Europe, similar scenarios there. Japan also, the data if you look at, well, if you look at the US data, they are using more of thymoglobulin. So I think it still remains a clinician and a center-specific regime. But what we have to consider is that ABO incompatible, number one, is a high-risk situation. Second, if there is no contraindication, then I have also shifted of using thymoglobulin or Grafalon in that situation. But you have to keep in mind that these patients are over immunosuppressed with rituximab and immunoexhaustion columns and plasmapheresis. So by adding thymoglobulin, you may be increasing the risk of infection. So I would still say that it's a center-specific and individual's decision, but more of interleukin-2 receptor blockers. But you can also use thymoglobulin.
So you mentioned the risk of infection. So Dr. TK Saha can now tell us a bit about the complications of induction therapy. Infectious and non-infectious both.
Yeah, you all know the learning gathering, they all know the complications of induction, particularly ATG and the others as well. So one interesting point, what I want to say to you that the way we manage the patient in other angle, like say, for example, what IV fluid you give, its blood sugar levels are very important. You see, I started using only Ringalector as the IV fluid for last few years, and I've seen the infection rates has come down. Earlier, you used to use, alternate dextrose and saline or RL. So, and I'm not giving a single dextrose unless the patient develops sugar which is below 80 or so that we can give it dextrose, 25 dextrose or so. So the earlier we start the oral feeding, the less we give dextrose containing fluid, the less we use, drain. And there are so many, other areas to decrease the infection. If you try to not use the induction with the fear of infection, you may end up giving more immunosuppression if you develop rejection. So our focus should be to decrease the infection. And I think we must all agree that after the COVID, the other infection, even in transplant scenario, has come down. Isn't that true?
Agreed.
So the use of mask has helped. So similarly, there are other preventive areas to decrease the infection. We should rather focus on that rather than decreasing the ATG dose or blaming the induction.
This is the wild card entry, my last question. So in WCN in Bangkok, from Deccan Hospital, Hyderabad, there was a paper of Renaissance with equine ATG. We have all seen non-availability of thymoglobulin some time back. Thymo and ATLG are both imported products. So they depend on the supply chain. We have a made in India product, which is not expensive, which is the equine ATG. And to comment on that, we have a wildcard entry, General PP Verma, who agreed just 2 hours back to take this question. Dr. PP Verma, sir.
I think it's a very difficult question to answer. We have been using equine ATG in our olden times. And at that time, the dose used to be 10 milligram per kg body weight. Rather, we did a trial that time. And there are 5 centers, Dr. Bharat Shah, our center, Dr. Nayak. We did a single dose equine ATG study. And we gave 25 milligram per kg body weight. See, whatever the literature is, the efficacy wise, it is not very inferior. The short-term studies are almost identical, but if you look at the 5-year survival graft and patient, it is certainly inferior to rabbit ATG. Mind you, rabbit ATG depletes more of CD3, CD4 cells vis-a-vis equine. So rabbit is more potent. Equine is less potent. So logically, if it is less potent, you should have less infections also. Because the CD3, CD4 count has not dipped down. So I really don't know, but we always face that time lot of reactions. And even the serum sickness used to be there. Besides the normal ATG reaction, what you have got fever and cough and pulmonary, whatever, the cytokine release phenomena, there used to be serum sickness and other problems. So, but your question that in case a person doesn't have ATG available or there is no drug, I don't foresee that it should be denied. Because the drug is half the price of rabbit ATG. It is produced in India by Serum Institute. It is easily available. Somehow, after the rabbit ATG came, it has totally disappeared from market. But I personally feel at time of crisis, and if you really want to save money, I think there was a study from, as you mentioned, in WCN, they compared the rabbit and equine ATG in not a very large study, but just around 35, 40 patients. And they found that it was almost equally effective as rabbit. So therefore, one should keep in mind, and maybe there is a place for equine if one is looking for a cheaper version. Yeah.
So because the 10 milligram per kg dose, single dose, rejection only 11%, no infusion reactions. So for a 50 kg individual, it's just 2 vials, which is 25,000 rupees. So definitely, if money does matter, we can talk about it. We have three chairpersons with us. So definitely, I have saved some time for them to give one comment each.
I would like to go on the ATG equine because I was part of the trial initially
Yes, sir.
with Dr. Naik only.
Yeah,
But,
we were part of that.
but I did have few problems like thrombocytopenia, DAC. So I didn't continue with the trial. But having said that, about 3 months ago, I was in Zambia and we did about 5 transplants and I was expecting rabbit thymoglobulin. They said they got, before I went, they said we got thymo and went there and saw it was equine thymoglobulin. So I was not sure what to do and I was very scared to use it. And patient had delayed graft function and I had to use it. The nephrologist there said that the hematologists are using it for aplastic anemia. They're not having any problem. And I used in 5 cases. They responded well. So I think there is a chance for trying this Make in India product. Maybe we should relook at the thing and have our own study. I don't know. So I don't want to be biased, but the Zambian experience using this gave me a little more confidence on this product.
Dr. Vishal.
I think all old timers have used it in n number of patients. Dr. Sharma, you also must have used it hundreds of patients. The hematologists are using left, right, and center in aplastic anemia.
Patient where I used thymoglobulin way back in 7980 was actually equine. We imported it from USA. But what I would like to say that most of the equine ATG which is being marketed by Bharat Serum, like even in Sanjay Gandhi PGI, it was being used by hematologists, bone marrow transplant and the aplastic anemia. So I think it is useful. I'm not saying that it has, when it can be useful in aplastic anemia, but until we have studies available which are randomized and which are showing its efficacy, because even for thymoglobulin and interleukin-2 receptor, there are good data, randomized studies, but the ultimate conclusions are very doubtful. Yes. Only rejections have come down. The survival is no different. 1 year survival is better, but 2 years not. So I think those are the points which come to a clinician's mind. And that's why they decide. And most of the nephrologists are not using this thymoglobulin.
Vishal, some comments from you.
Well, I think you have increased the spectrum of this panel, starting from depleting, non-depleting versus ATG versus ATLG. Then you are coming to equine. But I'm sitting with stalwarts all here. I feel so honored that they have used and they have seen an era of equine where we haven't seen that era. So I'm not an expert to comment on that.
Comment on anything else. The entire panel is open for you.
So what I would like to say is that the basic discussion was, one, whether to give induction or not to give an induction, and then what induction to be given. So they are the two basic questions that I think each of us has to decide. And whenever we take a decision as a transplant physician, we should be always, there is no blanket therapy, there's no blanket answer. I can very well understand that. You have to individualize your patient, you have to customize your immunosuppression as per your patient, and then only you can come to a decision whether you want to use, you can start from earning your dinner tonight to going to other brands, depleting or towards basiliximab. But I think the plethora is big, and with the newer agents coming now for induction therapies, monthly injections, belatacept and all those things, I think the paradigm will shift. So from the conventional agents that we have been using for years now, as we will get more of these drugs in the Indian market with time, I think we'll see more of newer drugs because they'll be easier to use, maybe once a month immunosuppression. I mean, those will be the things that I would look at the future of immunosuppression rather than what has happened in the last, since 1954 till date, maybe the next 10, 15 years where a lot of drugs are in the pipeline, the future in transplants, which are off label currently, but we may see a new horizon at that time. I think I agree with you, Ritesh.
Yeah, please, Ritesh. A concluding note from you would be nice.
No concluding note, just a point. When you're talking about basiliximab, what we fail to consider is the cyclosporin versus the tacrolimus-based immunosuppression. So most of the studies which recommended the use of basiliximab were cyclosporin-based, where you needed to treat 7 patients to prevent 1 rejection, whereas in tacrolimus you need to treat 80 patients to prevent 1 rejection. So in TAC-based immunosuppression, there's hardly any role for basiliximab, except maybe when you're talking about avian compatible. But I think most of, and when you look at the cost, and the weight of Indian patients, thymoglobulin is definitely more cost effective.
So I think that has been a very, very good discussion and contribution of the panelists. Probably we can take 2 comments from the audience.
What? Excuse. Hello. One. Am I audible? One comment about RL, ringer lactate as a replacement for post-transplant. RL is being used just to prevent hyperkalemia post-transplant because infusion, yes, sir. I'll clarify that acid-base physiology about it. Because NS causes volume expansion and hyperkalemic metabolic acidosis. There has been a large study in United States when they started using RL. That decreased, not increased, decreased the risk of hyperkalemia because ringer lactate, the lactate is converted into 2 molecules of bicarbonate when it enters the liver. So that decreases the risk of acidosis and then decrease the risk of post-operative hyperkalemia in transplant patient. That was the basis for use of RL. Secondly, whenever you transplant, the urine electrolyte excretion, that is a sodium excretion, is somewhere between 80 to 90. So that is the basis for use of either alternate NS and half NS, because NS started causing hyperkalemia and hyperchloremic metabolic acidosis. They replaced it to RL. RL is having a sodium content plus potassium content together of 140. So 140 there and half NS alternating. It reaches the excretion of urinary excretion of sodium around 80 to 100.
This point is well taken. That is how the genesis of 5% and alternate saline, because whatever is excreted, it is half saline. So just to make it half saline, you are taking saline plus 5%.
I think last 2 comments.
That is in details crisis. And
Last 2 comments.
Like there are patients who receive rituximab for the native kidney disease like lupus and all that. In fact, we have seen the rheumatologists, they are using massive doses of rituximab. So part A of the question is, if the patient has been exposed to depleting antibody like rituximab, should we monitor the post-transplant immunosuppression in this patient A? And the part B is rheumatologists, they keep frequently monitoring the immunoglobulin levels. And based on those, if the immunoglobulin level falls low, they give IVIG top up, so that the risk of infection in rheumatologists is less, as they say. So should we monitor the immunoglobulin level and give top up IVIG if needed to prevent the infection?
I think we'll all have to read that. And how about, sir, last query?
Actually, we started our disease owner transplantation program.
He is using a lot of rituximab.
Actually, we started our disease owner transplantation program with no induction. We were not getting it actually. So without induction, we started. And we had very good results and we never had any problem also. The 2 in unrelated transplants. So over a period of time, once we started getting a free of cost ATG, we started using it alternate day. So alternate patient, like one patient with induction, other patient without induction. This last year we published in Angel Nephrology also, that without induction also we did well. Only problem is that the slight risk of rejection, which is more compared to with the induction group, but the risk of sepsis and mortality was significantly high with ATG induction. So we should be very, very careful. Either the dose had to be modified, or now we started giving a less dose of ATG now, looking at the risk of sepsis and all. Otherwise, without induction also we did very well. And I know that some of the centers in the country also were doing without induction in transplantation, even in diseased donor.
So before I give you the mic, I want to invite all of you on behalf of Sir Gangaram Hospital organizing the 10th Asia Pacific Chapter meeting of the International Society of Peritoneal Dialysis. This is from 22nd to 24th September. And this may be slightly bad news for Dr. Umesh Khanna, because 3 of your 7 people are from Gangaram. And they will have to be there for the alumni meeting. So the picture which is showed, in which Kidney Associates Private Limited, half of them are our alumni. We feel so proud of the fact. and probably you will miss them on 21st September. That is when we have the alumni annual meeting. We are now probably 100 odd alumni from Gangaram. So you will miss Gaurav, Nikita, and Akash on that day. Thank you so much, sir. Thank you, sir.